This conference will now be recorded.
Hello. Okay. Are the students ready?
Yes, sir. Yes, sir.
Hello. Hmm. Okay. Today class is not a one-way class; it's a two-way class. So that I require response from you people also. So that it is because today we will be discussing about the case perform of the GIT system. GIT. Okay. So usually this is to be taken the initiation of the GIT system, but I have postponed it intentionally so that it will be a two-way class, so that you people can tell me the probable diagnosis with the symptoms with which the patients present to the OPD or a casualty. Okay. So what are the symptoms with which the patients present to casualty or OPD or the GA system symptoms with which patients present to GAT, casualty or OPD? Hello. Am I audible or not?
Yes, sir.
Abdominal pain.
Tell me that what are the GA system symptoms with which the patients present to the casualty or OPD? Come on, try. Is everyone ready? Hello.
Sir. Appendicitis.
Yeah. What are the? Huh? Ascites is
Abdominal
a
pain,
medical.
vomiting, diarrhea,
Yeah. One is abdominal pain, vomiting. Next, diarrhea. Next,
diarrhea,
diarrhea. Okay, accepted. Diarrhea is also a medical terminology. So you should tell symptoms
loose
should
stools.
be in the loose stools. Yes. And someone I heard that they said that it is ascites, but ascites is also medical terminology. So for that you can tell that it is distension of abdomen. Still, what complaints with what complaints the patient come to OPD or casualty?
Dyspepsia,
Dyspepsia is again a medical terminology.
retrosternal burning,
Retrosternal burning sensation. Yes. Still what more?
bloating of the abdomen,
Yeah, bloating sensation of the abdomen, epigastric fullness.
bleeding
Still
stools, blood in stools,
bleeding stools. That is that they can't tell blood. They can tell altered color of stools. It may not be blood. Blood also they can complain. And second one is related to that is altered color of the stools, which indicates if there is a history of melena and history of melena is present, then it is altered color of the stools. Next
constipation,
what? Yeah, constipation. Okay. So almost you have covered everything, but one thing is jaundice, that is yellowish discoloration of eyes or yellowish discoloration of urine. The patients of jaundice present to the OPD, that there is yellowish discoloration and there is history of loss of appetite. loss of appetite may be due to abdominal fullness, abdominal bloating sensation, or there is a loss of this loss of appetite may be due to abdominal fullness, abdominal bloating sensation, or sometimes the patients may feel panic of getting retrosternal burning sensation after the food intake. So they skip their meals so that there will be continuous skip of taking meals. So there will be decreased appetite. So all those things, these are the most commonly bleeding per rectum and arterial cholesterol. These are the most common complaints with which the patient presents to you in the casualty or an OPD. So depending on, so once the case, the chief complaint is over, you have to elaborate that chief complaint. So if the patient is having pain, you should ask the how to elaborate, how will you elaborate that pain. You should ask what is since how long that pain is present, how it initially started, and at what site. So what site this site gives you some indications depending on the structures. So if the patient complains of pain in right hypochondrium, what are the structures present in the right hypochondrium? Hello.
Liver,
Liver,
gallbladder,
gallbladder,
Yeah, liver and gallbladder. So if the patient complains of right hypochondriac pain, what can be the possible etiologies?
any abscess in
That is
right liver,
liver abscess. Okay. Before to that,
cholecystitis,
before liver abscess, you can tell that because in liver abscess there will be associated fever will be there. So only pain in right hypochondrium.
cholecystitis, cholelithiasis,
Cholecystitis, cholelithiasis. Okay. Next, simpler to that. In your previous classes, we have discussed the first stage of liver, first stage of liver failure.
hepatitis,
What is that?
hepatitis, sir.
Before the hepatitis, there is fatty liver.
fatty liver,
Yeah, before the hepatitis, there is fatty liver. So only the pain in right hypochondrium, there will be some discomfort type of pain. They clearly can't tell what is the type of that pain, but they can tell that right hypochondrium discomfort is there, and there is a history of decreased interest to take food, and this suggests fatty liver. And second thing is, if the patient is having cholelithiasis, and based on the radiation of the type of pain, what is the type of pain in cholelithiasis and cholecystitis?
colic type of colicky pain,
Colicky pain or sudden catchy pain will be there on taking deep breath, and where the depending on the radiation. So the pain of based on the radiation, how can you tell the pain, which type of pain it is?
two arms by diaphragm,
Usually the cholelithiasis pain that radiates to the right shoulder, and in case of cardiac, that is inferior valami, it usually radiates to the epigastric region. So in renal calculi patient, in the case of renal calculi, the pain usually radiates from loin to groin. Okay, based on this radiation, you can have some probable diagnosis. What can be that? Okay, and next coming to the aggravating factors. What are the aggravating factors of the pain? How it aggravates? So in some cases like myalgias, these myalgias usually aggravates on exercise or doing any work like lifting weights and all those things. There will be aggravate, or some cases of cost this cases like costochondritis and all those things, they aggravate on these inflammatory conditions. They aggravate on like minimal touch and all those things. So these aggravating factors gives some clue. Then what are the relieving factors of the pain? If the pain that is subsiding on rest, it is usually these may be myalgias, and you can also associate symptoms. So you have said that liver abscess and all those things. So if there is a pain that is associated with fever, if there is a pain in the right hypochondrium and associated with fever which is a high grade, and there is decreased appetite and all those things, jaundice and all those things associated, then you can have a probable diagnosis of a liver abscess or a hepatitis or liver infection and all those things. So these associated symptoms also give us a clue to our diagnosis. That is diagnosis, main diagnosis, or a differential diagnosis. Next, coming to the vomitings. So for every complaint, you should duration of that complaint and frequency. So what frequency means that is number of episodes of vomiting per the 24 hours. So depending upon the frequency, you can decide whether you have to act immediately or you can take some time. And also if the vomiting, whether it is associated with nausea or without associated with nausea. So usually you will have some diagnosis, some differential diagnosis. If the vomiting is associated with nausea, it is related to so if there is vomiting that is associated with nausea, it is usually due to gastritis and all those things. And if it is sudden vomit is usually
Neurological.
projectile, which usually neurological related to central nervous system. So if the vomiting, there is a presence of abdominal pain at the vomiting, at the site of vomiting. So what it suggests?
Obstruction.
Then there is when the food intake and any obstructive gastric outlet obstruction and all those things, there will be pain and which will be relieved after vomitings. So you should also ask the contents of the vomiters. So what does the contents of the vomiters will tell you?
Bilious type.
What the contents won't tell that. Contents will tell you what whether it is due to what is the probable etiology for that vomiting. It may be due to indigestion, it may be due to gastric outlet obstruction, or any obstruction due to the large bowels. That is that pressure becomes backward flow occurs. So in that case, contents, if there is indigestion, it is associated with foul smelling, and the food particles will be present as is the patient has taken, and the contents the what is the food substance that the patient took in the previous meal. And the color suggests whether it is bilious vomiting or a non-bilious vomiting, or the color of the vomiters also suggests in case of ulcer, GI ulcers, and all those things, there will be red color
Coffee
in
colored.
the vomiters. Coffee colored or red color. Sometimes if there is any esophageal stricture, or in case of esophageal varices or any ulcer of the stomach ulcers, in those conditions there will be coffee colored or red colored in the vomiters. So with the color you can diagnose, you can assume that whether the patient is having so and so complaint, and whether projectile or non-projectile. We have discussed that whether when it is projectile, you should think of the CNS pathology, that is a raised intracranial tension, that in that occurs in case of tumors, any hemorrhage, or any massive infarcts and all those things. So, and again, non-projected is usually in the GI system, GI pathology, and the blood in the vomiters. So we have already discussed that blood in the vomiters, whether it is fresh or altered. Fresh blood in the vomiters suggests usually
Malignancies.
any throat malignancies. In all those things, there will be fresh blood or any altered color of the blood is seen in the stomach
Ulcers.
pathology in the stomach, ulcers, or in this fresh blood in the vomiters is usually seen in this esophagitis and all those things conditions. And then associated symptoms, whether it is associated with foul smelling and all those things, and all. So it gives a clue to your diagnosis. Next, loose stools. So what is the loose stools? Duration and frequency. I already told how many loose stools per day for 24 hours. Type of stool. What is the type of stools? Whether it is a water in consistency or in the rice water or semi-solid. So what is the rice watery stool suggests? Rice watery
Cholera.
stools.
Cholera.
Yes. Most probable diagnosis of rice watery stool is cholera and till.
Arsenic poisoning.
Yes, arsenic poisoning, and in cyanide poisonings also there will be rice water stools. So and so this type of stool usually indicates the consistency. You should the consistency of the stools. And what is the type? Next, contents. What does this contains? You can't see undigested food particles in the stools. Most commonly you won't see. So contents is usually worms. You have see any worms or anything in the stools. And next is color of the stool. Color of the stool indicates, what is the color of the stool indicates?
Pale color stools.
What it indicates? Pale color stools indicate.
Obstructive jaundice.
Yeah, pale color stools, obstructive jaundice is there, but there will be clay colored stools, formed stools will be there, no, not loose stools. So presence of loose stools color indicates the most probably the causative organism. What organism causes the stools? So and presence of blood or mucus in the stools usually indicates mucus. Again, the mucus indicates any
Infections.
anal fistulas, anal fissures, or any infectious etiologies. So presence of blood in stools indicates, one is if there is a presence of blood in the loose stools, or in a patient of old age, first probable diagnosis
Colorectal.
will be colorectal carcinomas. Colorectal carcinomas. That is the first possible diagnosis. Next, coming to any hemorrhoids, internal or external hemorrhoids, or next is any anal fissures or anal fistulas. So you should, this is your probable diagnosis. Next, coming to the associated symptoms. What are the associated symptoms? Associated symptoms like any loss of weight. If the presence of loose stools with blood and is symptom of loss of weight, most probable diagnosis comes again colorectal malignancies. It may be colorectal or any rectal, only rectal malignancy, or that these can be the malignancies, can be the possible diagnosis. So taking all these elaborating all these complaints in the one for this one single complaint gives a list of probable diagnosis. Next, coming to whether there is any loss of appetite. So loss of appetite usually duration you have since how long for any particular type of food, that is only for liquid food or for a solid food. So initially in case of esophageal malignancies or throat malignancies, initially the patient complains of difficult loss of appetite to take solid food followed by liquids. So there will be pain during taking the solid food. So for that, to avoid that pain, the patient won't take the solid food initially, and followed by liquid food also there will be appetite. So in there is loss of appetite followed by loss of weight is present. So it indicates mostly malignancy condition. And bleeding per rectum. So bleeding per rectum, you should ask the amount of bleed so that it tells you whether to intervene early, or you can write any. You can wait for a long such duration, or whether it is a flank. The color is altered. When the color is altered, mostly it indicates the upper GI pathology. And if there is any frank blood, it indicates whether it can be in hemorrhoids or anal fissure. And if there is streaky blood, it indicates some malignancy, the colorectal malignancy. And relation to defecation, if there is blood, if there is a forceful defecation is present, and with that the blood occurs, so it may be mostly any fissures or hemorrhoids. So whether there is history of melena or hematochezia, that is hematochezia is fresh blood. Melena is black colored blood, black colored tarry foul smelling blood, foul smelling stools. So coming to again jaundice, and since how long it is present, how it was it noticed, whether how it was noticed, you should ask whether it was noticed by the person himself, or by any family member, or by any friend or a close relative who said there is an yellowish discoloration of the eyes, or the patient having any high colored urine, or any history of clay colored stools or a pruritus. This history of clay colored stools or pruritus is usually seen in an obstructive jaundice, or any history of drug intake. So some drugs like ART, that is this ATT is anti-tubercular drugs. This anti-tubercular drugs, most of the anti-tubercular drugs called hepatotoxic. So you have to take the drug history to see whether any impending drug that causes jaundice, or associated symptoms like loss of appetite, loss of if there is presence of jaundice associated with pain abdomen with loss of appetite and all those things, most probably you should think of liver etiology. So when coming to this completes the history of present illness. So history of present illness, you should also ask the negative history. If the patient is also having pain complaint, so you should ask the negative history of other complaints will be negative. Whether there is any history of jaundice, any history of altered blood in stools and all those things, you should have the negative history. So in at the end of history taking, and at the end of history of present illness, you should know how much will be the what are the probable list of differential diagnosis. You should be able to summarize them. And these coming to past history, or whether these complaints are at the first time, or whether they occurred in the past. So any history of recurrent episodes of jaundice that is occurring in a person, you can think of what you can think of recurrent jaundice. What are the complaints? What are the diagnosis you can think of the person having recurrent episodes of jaundice? Are you interested in the two-way, or shall I continue in the one-way? One-way class, so that I will be talking and you will be listening. Hello. Hello. Are you people interested in two-way or one-way? Kindly respond, students.
Yes,
So,
sir.
coming to the past history. Yeah, you are interested in two-way or one-way? Pawan.
Two-way, sir.
Huh?
Two-way teaching, sir.
Which way? Two-way teaching. But you people should respond from your end to have a conversation. But if you people keeping quiet, how can I continue for a two-way class? So when there is an interaction between you people, it will be useful. I think, to my knowledge, it will be useful.
Yes, sir.
So what is the diagnosis you can think of when the patient is having recurrent episodes of jaundice in an elderly patient? I'm telling you the age of the patient also. It is an elderly patient, that is more than 60, with recurrent episodes of jaundice. What can be the differential diagnosis? Or what can be the diagnosis you can think of?
Alcoholic hepatitis.
Alcoholic
Hepatitis.
hepatitis. Alcoholic hepatitis. Okay. It can be one of the diagnoses. Next one. Patient alcoholic hepatitis need not be in an elderly patient. It can be in any patient. So in elderly, first initial diagnosis you should be thinking of is any malignancy. So any malignancy that causes that causes obstruction, and as sometimes this obstruction will be relieved by its own, so that it will again the patient becomes normal. Again the obstruction occurs. Again there will be jaundice and all those things will be occurring. And recurrent episodes of jaundice in a young patient, in young 10 to 15 years of age, you should think of that congenital hyperbilirubinemia, all those things. So again, you should then whether any history of diabetes or tuberculosis in the past. So these tuberculosis, because these tuberculosis may needs more attention, because these tuberculosis cause these drugs of anti-tubercular drugs are hepatotoxic. So in that case, you have to see that. And next, any previous hospitalizations, that is any history of hospitalization for any distension of abdomen, that is liver cell failure, any case of liver cell failure, or any history of blood transfusions. If any blood transfusions, there occurring of jaundice followed by blood transfusion, usually due to it may be due to this blood transfusion. ABO incompatibility is the most common cause, followed by any malaria or all those things, or any HBV or HCV infections, which are in window period at the time of testing. If they are transfused, then the patient get liver problems. Next, coming to the personal history. Personal history. What is the diet? What is what is the diet? That is, patient is a mixed diet, vegetarian or a vegetarian, or how is the appetite, whether the appetite is good or not, whether decreased, and where is sleep, how is the sleep habits or sleep pattern. The one of the leading point, if there is any early onset of sleep alteration, that is daytime sleepiness and nighttime awakening, that is altered sleep pattern, is the first stage of liver cell failure. When you stage the liver cell failure, in the initial stages there will be altered sleep pattern will be there. However, the bladder and bowel habits. So in bladder you should say you will ask any high colored urine is present, and in bowels you should ask what is the color of the bowel, whether it is any clay colored and all those things, and any habits. Smoking, if there is smoking, you should ask about duration of smoking, frequency, quality, and brand. This brand means not the cigarette brands. It may be what is the he's what type of smoke he is taking. That is whether a cigarette he is taking cigarettes, chutta or BD. You should convert them into cigar to convert the pack years, number of pack years of smoking. So for that conversion, one cigar is equal to 10 cigarettes, and one BD is equal to 4 cigarettes. And again alcohol for that duration, how frequently he takes, weekly once or daily he is taking, or weekly once or monthly once, or only in party, and if he takes at what quantity. So he takes 180 ml or 160 ml. And next, brand. This brand is for conversion. The one bottle of so to convert the grams of alcohol that is present in that. So one whiskey is equal to 4 beers, and it is equal to 12 beers. So that to know that for conversion of number of grams of alcohol is consuming. So for that you should ask the brand what type of alcohol is taking. Next is family history, whether he is married or single, and how are their brothers, sisters, and all those things, and what is the family hereditary or family history, familial diseases, that is any congenital diseases are usually hereditary, or any similar complaints in the family members. So like jaundice and all those things in the family members. Next, coming to any contact history. So or contact or any allergic history. Contact means any extramarital contacts whether present. So you can think of that any immunocompromised conditions and all those things, and allergic history. So at the end of history, you should be able to elaborate the provisional diagnosis. So in a provisional diagnosis, you have to tell that so and so age patient with, in provisional diagnosis, you have to tell the only positive history, and some useful negative history, that is which supports the diagnosis. So you should elaborate the entire history you have taken at the end of history, and you have to give a provisional diagnosis. So coming to the examination proper. So in examination, you should first examine the head to toe. That is, how is the general physical exam, then how is the build, nourishment, how is the consciousness and cooperation, and how is the orientation of the time, place, and person. And this pickle, you all know that pickle means not the pickle you eat in your rice. It indicates what is P stands for pallor, I icterus, C stands for clubbing, and again C for cyanosis, L for lymphadenopathy, E for pedal edema or any dependent edema. So you should see all this and any signs of liver cell failure like spider neve, telangiectasia, and all those things you should see. Next, coming to the next, you should measure the vital signs. So for describing the pulse, you should have 7 headings. 7 headings you should describe the pulse. That is rate, rhythm, volume, character, character, that is character, any radio or radiofemoral delays, peripheral pulses, and condition of the vessel wall. These are the 7 headings you should describe the pulse. And next is blood pressure. You should describe, for describing the blood pressure, you should see which arm and which position in which position you have measured the blood pressure. And coming to the respiration, you should describe it as in rate, and what is the type of respiration and rhythm of the respiration, whether it is regular or irregularly irregular. And next, coming to temperature, you should mention it. Temperature so and so degrees Fahrenheit, measure it oral or axilla or rectal temperature. Next, coming to the white examination. Next, coming to measurement of the height, weight, and body mass index, that is BMI. So coming to systemic examination. So systemic examination, that is for abdominal, is a systemic examination of GIT starts with examination of the mouth, oral cavity, tooth, tongue, and oropharynx. So in the mouth, what do you see? What is the oral hygiene of the patient in the mouth? Whether there is any in the mouth, you can see in the mouth you can see any ulcerations. In the gingival ulcerations are also present or not. And how is the oral hygiene? And in the tooth, you can say any decay of the tooth or any staining of the tooth seen in patients who consume tobacco or any gudka or pan parag and all those things. And tongue, any fissured tongue is there, or any striations over the tongue and all those things. And in oropharynx, how is the oropharynx? Is there any ulcers of the oropharynx or any bleeding spots in the oropharynx and all this, or any oropharyngeal congestion is present, and all those things you should examine. So coming to the examination of abdomen per se, that is inspection. So in inspection, you see the shape of the abdomen. What are the various shapes of the abdomen you know of? What is the normal shape of the abdomen? Pavan?
Sir,
Yeah. Kindly respond. You people said that you need a two-way interaction. So why, if you are not interacting from your end, it can't be two-way interaction.
okay.
So what is the normal shape of
Flat, scaphoid and protuberant, sir.
scaphoid? And is the normal shape of the abdomen is scaphoid abdomen, and various shapes of the abdomen are scaphoid, flat, and distended. Okay. So you should see what is the shape of the abdomen and where is the position of the umbilicus, how is the umbilicus, and what is the position of the umbilicus, how are the movements of the abdomen, that is all the quadrants of the abdomen with respiration. And you should see whether there are any engorged veins, and how is the skin over the abdomen, whether there are any scars or marks or any pigmentations present, whether there is any visible peristalsis, or how are the hernial orifices, or any divarication of recti, that is due to thin weakness of this rectal muscles, there will be splitting of this rectum, and there will be gap while patient patient is sitting from supine position. So in the midline, there will be gap will be present. So divarication of the recti can be seen. And scrotum. Is there any scrotal swellings? And any signs of chronic hepatocellular failure? What are the signs of chronic hepatocellular failure? So the signs of chronic hepatocellular failure are
Spider neve, palmar erythema,
from top to bottom. It is better. It is better to describe from top to bottom. That is head to toe. So what will be the signs from head? What will be there? There will be loss of hair. Loss of hair will be there. Second is shrunken faces. Okay. Next one is loss of axillary hair will be present.
Jaundice.
Then jaundice will be there. Next,
Spider nave.
spider nevia will present.
Amarerythema.
Gynecomastia in case of men will be present. Next, coming to the abdomen, there will be distension of the abdomen. Okay, distension of the abdomen will be present. Next,
SIT
thinning
is
of the limbs
portal
will be there.
hypertensogastropathy.
I couldn't hear you properly. Can you repeat?
SIT is portal hypertensogastropathies.
What are the findings you see in post-stroke gastrointestinal? What will be the signs symptoms you will see that on inspection? What will be the findings? Gastropathy. What will be the findings on inspection? Who is the person that answered that? Kindly answer. What are the gastropathy findings in in examination, in clinical examination? There's gastropathy and all those things you can tell in a clinical examination. So after completing this inspection, you should go to palpation. So palpation, you will see superficial palpation and deep palpation. In superficial palpation, you will see whether there is any tenderness or any guarding and rigidity present. And deep palpation, you will see the size of the liver, surface of the liver, over the margins of the liver, consistency, and presence of tenderness. In presence of tenderness in the liver is usually indicative of hepatitis or right heart failure. So right heart failure also there will be tenderness over the liver because of congestion. And coming to the spleen, so you should in the spleen, enlargement of the spleen can be taken as one of the indication of raised portal hypertension. That is portal hypertension, raised portal pressure. That is portal hypertension. So you should see the size. How is the surface of the liver, spleen? That is surface of the spleen, margin, consistency, and tenderness. And tender splenomegaly is usually seen in. Where you will see tender splenomegaly? It is usually seen in hemoglobinopathies. And coming to the kidneys, you will see. And how will you differentiate kidneys from the spleen or kidneys from the liver? How will you differentiate by palpation? That is, this is kidney, this is spleen, and this is liver. How can you tell that? Usually these kidneys are ballotable. That is, by bimanual examination, you can see ballotment of the structures. Only structures that are ballotable are the kidneys. Only structures that are in abdomen that are ballotable are kidneys. And next you have to see the measurements. What are the measurements you will see? Xiphisternum to umbilicus and umbilicus to suprapubic. From xiphisternum to umbilicus and from umbilicus to pubic symphysis. It denotes the whether umbilicus is in midline or not. Then umbilicus to right and left suprapubic prominence. Then you have to measure the whether there is presence of fluid trill or not. And next, how you have to in palpation you have to also see the whether the hernial orifices are intact or not. Then coming to the percussion, in percussion you will see whether there is any shifting dullness or not. And by organ percussion you can see the size of the liver or size of the spleen. Next, coming to auscultation. In auscultation you should see whether there are any peristaltic sounds, whether there are any hepatic or splenic arterial bruit, or whether there is venous hump, or the peristal. There you have to measure the number of bowel sounds. Usually the normal number of bowel sounds per minute is 3 to 4. If there is increased bowel sounds, it indicates the obstruction. Whether the bowel sounds are decreased, it indicates mostly what it indicates, the condition in which the bowel sounds are decreased, bowel sounds are decreased are seen in paralytic ileus. So hepatic or splenic rubs you can auscultate. Then coming to, you should examine the other systems. So you should in case of this examination of other systems to exclude the other system involvement causing GI pathology, that is any right heart failure is there, all those things. So coming to after that examination of other systems like the CVS, RS and CNS and followed by diagnosis of the case. You should come to a final diagnosis, and after diagnosis you should suggest the required investigations that are required to confirm your diagnosis and what will be your probable line of treatment. Up to this extent you should write in your case sheet pro forma while you are attending a university exams. So most of the people will stop at the diagnosis and most people will skip the examination of other systems. So you should not skip the examination of other systems because they add to your examination. So if you skip, in the case of right heart failure, if you skip examination of the CVS, it can't. You will tell that it is a case of ascites and treat that case as it is. But ultimately, the patient fails because the heart functioning is not proper. So if you examine CVS in case of right heart failure and abdomen, if you examine and next CVS, so it gives an indication of right heart failure and you will treat in that manner. So it helps in your diagnosis. Examination of the systems helps in your diagnosis. Then what are the investigations required that helps after examining the other systems? So then finally the treatment. What is the probable treatment? This helps you in treating the diagnosis. Is there any questions? Are there any questions? Hello?
No, sir.
No. Did you understand the class or not?
Yes, sir.
Did you understand? Now you can take a GA system pro forma individually. Yes or no?
We will, sir.
Huh? Yes
We
or
will try,
no?
sir. We will try, sir.
We will. Okay, that's good. Okay, now I will concluding the class. You give your attendance in the chat box.
Yes, sir.
Okay, okay. Thank you all for your patient listening.
Thank you, sir.
Thank you.